Very warm welcome to everyone who decided to dial in on Friday afternoon to the ERN webinar about Usher syndrome. We will have a broad presentation range, I think, today with 3 speakers. At first presentation, myself would show you a little bit the background of the Usher syndrome from the medical side, the clinical aspects. Then after me, Professor Simonelli will explain you in detail the disease of the Usher-1B syndrome, because she has done very much research on this subtype, including PI of an interventional trial. And in the end, a very important aspects from the daily life of the patients will be given by Dominique Sturz. We can slowly dive into the clinical aspects of the Usher syndrome, or better to say Usher syndromes. As you already know, there are many subtypes. Myself, I'm an ophthalmologist working in Germany in the University Eye Hospital in Tübingen, and my work is dedicated to inherited retinal diseases and clinical trials about these syndromes. So Usher syndrome is a syndrome that affects mostly two organs in the body, and this is the ear and the eye. If you consider this biologically, it's a so-called ciliopathy, especially if we talk about Usher type 1 and 2, because it affects the cilia in the body. It's a very rare disease, and the estimated prevalence is around 1 to 30,000, but of course, this is always different in different populations. The diseases, all of the subtypes are inherited in an autosomal recessive way. And when we talk about ciliopathies, you probably know that there are ciliar particles in the ear cells and also in the eye cells, in the photoreceptors, as shown here in the image. Let me do the pointer. In the photoreceptors, this very thin part of the cell of cone and rod, both, that is necessary to transport things between the outer and inner segment. This has cilia proteins, and as well it affects the hair cell in the inner ear. This is the actual hearing transferring cell in our ears. There are also other types of cilia in our body, and these are not necessarily neurologically relevant, although there is also a cilium in the nose, in the olfactory cilia. There are some indications that olfaction, the smelling, might be affected also in Usher syndrome, but it's not a very dominant symptom. Most of the patients are not aware of any decrease. Other cilia are well known in the respiratory tract, in the kidney, in spermatogenesis, in the sperms, and in other bodies, but these cilia are actually not affected in Usher syndromes, although there are, of course, other syndromes which might affect all of them. So here we will talk only about the hearing and the vision loss. We have several types of Usher syndrome, and we have said already there is type 1 and type 2. Currently, there are 4 known types, so to say 1 to 4, and the type 1 is the, I would say, most severe one. Here in this cases, we have deafness, which is congenital, meaning present already at birth. It's quite profound, a sensory neural hearing loss. Basically, all the children are deaf, born and with a very profound impairment, and also the vestibular nerve is affected. So we have here balance difficulties that are quite obvious in some children, and on the eye side, the classical retinitis pigmentosa. This retinitis pigmentosa doesn't have a congenital start, but develops through the lifespan and starts usually relatively early in some patients in childhood already. Others notice first symptoms in the adolescence, in the teenage. The type 2 is a little bit less severe, where we have only hearing loss, congenital also, and no vestibular areflexia, no balance problems, and children develop retinitis pigmentosa rather in a little bit later age, meaning more of the teenage span and young adulthood, where first symptoms become obvious. We have the type 3 also, which is quite rare among these rare syndromes have been described, especially in Finland and also in the United States. And very recent type 4 that has been described in the last years. And this type 4 is characterized by rather late onset symptoms for both neurosensory problems. I have said already there is an autosomal recessive inheritance for all of them, and this is a little bit older diagram, but shows quite well that USH2A, the Usher syndrome 2, is the most prevalent one, followed by Usher syndrome 1B, and there are several well-known genes also causing Usher syndrome, but all of them are inherited in an autosomal recessive manner, meaning parents carriers, and then 25% chance to have an affected child. If we make a little bit closer look to the subtypes of Usher syndrome, then Usher syndrome 1, the most severe one, has 5 genes that are well known for the association with the disease, and we will learn much more in the second talk about MYO7A being the WASH1B syndrome. Here, the congenital deafness, as I said already, is quite clear already in babies. The children being deaf do not develop speech properly or at all, and moreover, these children have balance problems. So that another problem that the parents are encountered with is a delayed walking due to this vestibular areflexia and balance difficulties. And sooner or later, depending on which newborn screening is available in the country where the babies are born, these children receive cochlear implants usually. On the eye side, the classical retinitis pigmentosa is to be expected with first symptom, mostly night blindness or peripheral defects of the visual field. And the blindness can occur here in young or middle adulthood, but also different cases are known, and each course of the disease is quite individual. In contrary, Usher syndrome 2 is the less severe one. We know here mostly 3 genes which are associated with this subtype of Usher syndrome, and on the hearing side we have a hearing impairment that can be very light or can be close to deafness. This range is really very broad, and as you, for example, might know, for the USH2A gene, that can cause also a pure retinitis pigmentosa without hearing impairment. The range, the extent of hearing impairment can then reach from complete none to a very severe, neighboring to the deafness border. Patients usually use hearing aids if they need any. And again, retinitis pigmentosa starts with night blindness or peripheral defects of the visual field, and the blindness per se is expected later than in the Usher syndrome 1. With Usher syndrome 3, as I mentioned, being described mostly in Finland families or United States, is a CLRN1 gene, and here we have not a congenital and clear, but a progressive hearing loss with babies being born with normal hearing, but deafness in the middle age without vestibular involvement, and retinitis pigmentosa again on the ophthalmological findings with progressive vision loss. The last subtype, Usher syndrome 4, has been described in last years. This is the newest, the most recent one. It's associated with ARSG gene, and it's also not an inborn problem, because here we have usually late onset of both difficulties, hearing and vision. We have a late onset of progressive sensorineural hearing loss, sometimes or often even after or in the second life half, and also a late onset of retinitis pigmentosa. So this type of Usher syndrome seems to be the less severe one, and also we do not have any vestibular involvement here. According to what you know about retinitis pigmentosa, probably it's the classical retinitis pigmentosa that we can expect in the Usher syndromes. The ophthalmological findings, if we don't have the genetic report, are basically not distinguishable from non-syndromic retinitis pigmentosa, with all the variability that is given inside of the disease. We have a rod cone degeneration, usually with starting rod degeneration followed by cones, and the ophthalmological findings are the same with bone specular pigments, as you know. So bone specular pigments can be very scarce or more pronounced, often in the middle periphery, and have this typical resemblance as is shown in the image. The initial manifestation is often night blindness because of the rod functional decrease, and sooner or later we have defects of the visual field, mostly ring scotomas, starting in the middle periphery, but can be developing also from the far periphery and closing to the center. This would be an example of ring scotomas, like here, this mid-peripheral involvement, which enlarges then to all sides in later stages, leaving these peripheral islands and central islands, and in the end, then closing the visual field to a very strong constriction and followed by blindness. In OCT, a typical finding of this smooth degeneration of layers, concentrically shaped, and in comparison to a normal retina, this would be an end stage of retinitis pigmentosa, either non-syndromic or syndromic. As I said, it's not well distinguishable on the clinical findings in the OCT with an atrophy of outer retinal layers. The natural cause is progressive, the complete loss of vision can follow depending on the genotype, but surely also depending on exogenic factors in the middle age or later. And typically visual acuity and cone function are affected rather later, although Usher syndromes being ciliopathies, they affect both cones and rods, so that in many patients this degeneration is in parallel, not typical like in other genes, first a complete rod disorder and then following cone. This can be very different in individual patients, even inside of families. Accompanying problems, again, here possible also, all what we know from retinitis pigmentosa, narrowing of vessels, dysfunction of the retinal vascular system, waxy optic nerve head, especially in the later stages, and bone specular or wide atrophy, as we have shown before. The macular edema or epiretinal membranes are common too with retinitis pigmentosa and especially early or middle stages, and the posterior capsular cataract that can be solved with cataract surgery. This is an example of the posterior capsular cataract in the slit lamp. The cystoid macular edema is an important thing to know, especially in patients that are not yet properly diagnosed and do have hearing loss. Macular edema in retinitis pigmentosa, syndromic or non-syndromic, can be mistaken for uveitis. And here I only wanted to depict this image because it shows again this very smooth degeneration of retinal layers that is so typical for hereditary disorders, and above it the macular edema that very probably must be considered a genetic one and not an uveitic one, being treated with heavy anti-inflammatory medications that often do not affect retinitis pigmentosa macular edema. The progression of retinitis pigmentosa, and here especially the gene USH2A, is known for long. We have this exponential loss of the area in the visual field with very fast progression in young years, then slowing down, and many patients stay on the tunnel vision over years or even decades until blindness. Many patients do not reach the complete blindness stage at all. There have been an observational trial in 10, 14 years ago in Europe, which included more than 300 Usher patients of all types, and we learned a lot about the genotype-phenotype correlations. Here is just an example how the visual field can vary, and you see here already with USH1 subtypes, the visual field is quite small already in the 20s, whereas there are such patients with USH2 also, but the possibility to have a large visual field is relatively higher in the second subtype than in the first subtype. The same is true for visual acuity, and here in these diagrams, of course, the y-axis to the higher part is the worst one, to the lower side is the better one, and we see a wide spread of the visual acuities among all cohorts, basically. If you consider visual acuity only among the most common subtypes, 1 versus 2, then you see that in the beginning, again, the Usher syndrome type 2 is the better one or the less severe one, whereas then later in the progressing age, they can quite be on the same level. And here another depiction of the comparison, and this doesn't show the actual area of the visual field or the visual acuity, so to say, but it shows the amount or the percentage of people who reached blindness in a specific age. And here at the age of 40, based on the American regulation for blindness, which is a little bit less strict than, for example, the German one, you see that around 40, half of the patients with Usher 1 reach the blindness stage, whereas for Usher 2, this is only between 50 and 60 years of age. Currently, we have also several more observational trials I would like to mention. 2 of them are sponsored by Foundation Fighting Blindness in the United States, and here it's an international and multicentric trial where our site in Tübingen has also participated. It actually ended already 4 years, ended in 2022, but it decided to be continued, and we included more than 120 patients worldwide with USH2A related retinal degenerations. There have been some publications showing also valuable observations, but due to time I will not go into details, but would like to mention the other clinical trial with Usher syndrome from Foundation Fighting Blindness, where I have the honor to be the study chair. This is an observational study on Usher 1F, PCDH15 related retinal degenerations, and because this is so rare, we've been happy finally to include 40 patients worldwide. It's a really very rare condition, and fortunately also based in the United States, there is a foundation dedicated specifically to Usher syndrome 1F that is also supporting research, genetic treatment in several labs. You can find it if you're interested on this webpage. So the Usher 1F collaborative is a strong mover here in this area. Regardless of treatment development, what can we do for this patient? So we usually follow them hand in hand with ENT specialists. Young children receive mostly annual examinations, depending on the hearing pattern, and also otoscopy or classical audiometry to follow up. And on the eye side, we support patients with specific aids. First things to mention is orientation mobility training, which is necessary rather in later stages. The same for magnifying reading aids, and this depends on the country regulation, how can it be pursued. Very important is connecting to patients organizations. Here, what I have written is a German patient organization, ProRetina, but of course, Retina International, and there are also local connections to patients with Usher syndrome in almost each country. Legal definition for visual impairment with a specific card are necessary, and here the combination of two sensory impairment can even have more importance in the disability definition. Filtering glasses for UV protection, and of course career counseling, and talking about the driving license depending on the regulation in the particular country. Now, these are the tasks for an ophthalmologist to at least speak about when consulting patients with defined or confirmed, genetically and clinically confirmed Usher syndrome. Okay, this is another slide. What I said already, again, Living with Usher syndrome is a German patient organization dedicated specifically to Usher syndrome, but they might be more of them worldwide, and of course, connection to the ERN-EYE network we are meeting now within. It's a very good possibility to exchange information inside of Europe. In my last part of the presentation, I would just like go shortly through a treatment approach, because the genetic treatment is not available yet for USH2A. We will hear in the next presentation approaches about the Usher type 1 gene therapy. But here, just to close the loop, there is an approach, although not specifically genetic replacement therapy, but an RNA treatment that has already started a few years ago in European and US sites, has been stopped due to financial problems, and will hopefully proceed next year soon. This is a RNA treatment which is meant to treat specific mutations of USH2A. USH2A is encoding a protein called usherin that is as I said before, a cellular protein important for the maintenance of the cell structure. And in the USH2A gene, which is very large, has 71 exons, there is this exon 13 included, where most commonly in the Western world, here I wrote in Germany, but it's actually also true for most of European countries and US. There, the most of the mutations are lying inside of the exon 13. We have estimations about 16,000 people being affected in the Western world by exon 3 mutations of the USH2A gene. And interestingly, excluding exon 13, like incomplete the exon from the protein transcription, will not make much damage to the functionality of the protein usherin, because the cell can create a shorter protein, but still a functional one. And this thought has given rise to a treatment approach in the Netherlands, and so to say an skipping of exon 13 approach by an antisense oligonucleotide RNA, which can be demonstrated here in this slide. So imagine you have a normal photoreceptor as here, with USH2A information transfers to the mRNA based on the pre-mRNA and splicing. Normal protein usherin is expressed. But if there is a exon 13 mutation, then there is a problem, and on this spot the protein translation is usually cancelled or stopped, or leads to problems, and then not a normal functional usherin protein can be produced. The cell degenerates. Here with the RNA approach, we act on the level of the pre-mRNA in the cell process of protein transcription, whereas this antisense particle can connect to the whole exon 13, make it, so to say, invisible for the process of protein transcription, and then the cell splicing leads to a shorter information without exon 13. Such an RNA, messenger RNA is then the background for the shorter but functional usherin protein, and the cell then doesn't undergo degeneration and can be rescued. These injections of antisense oligonucleotides must be repeated every half a year, because RNA, as you know, is a non-stable protein, a non-stable molecule, and it can be degraded in the cell. But there have been some results showing acceptable safety and quite good function, efficacy in many of the patients. So we hope that this trial will proceed next year again. Last but not least, if you ask yourself what exactly is exon 13, then you can find this in your genetic report. Exon 13 spreads from the C point 2169 point of the genetic information until the 2808. Any mutation which is in between these borders can be considered as exon 13 mutation. For example, the very common C2276, or also others. It's of course enough when either maternal or paternal inherited mutation is exon 13. It is not necessarily that both of them must be exon 13. So for these patients, I hope we might have some help in an experimental treatment soon. And by this, I hope I have given the most important background information for the clinical aspects of Usher syndrome. And I thank you very much for your attention. And with this, I would like to give the word to Professor Francesca Simonelli. Thank you very much.
Good evening. I'm Francesca Simonelli, Chairman of Eye Clinic and Referral Center for Inherited Retinal Dystrophies in Naples, Italy. These are my financial disclosure. As Professor Stingl told, Usher syndrome type 1 is characterized by severe to profound hearing loss and early onset retinitis pigmentosa. Type 1b is due to mutations in the myosin 7a gene, accounting for about 45% of Usher type 1 cases. Currently, there is no approved treatment, unfortunately. We performed a project dedicated to patients with Usher type 1b syndrome. The project, named Usher Project, was funded from the European Union Horizon 2020 and included a lot of participants, as you can see. Foundation Teleton in Italy, that is the coordinator, and Institut National de la Santé de la Recherche in France, CHINOSEF, and 3 clinical centers, our university in Naples, in Italy, Instituto Investigación Sanitaria Fundación Jiménez Díaz in Madrid, Spain, Stickling Eye Hospital in Rotterdam, Netherlands, and then RITERA and University of Milan for the statistical analysis. The Usher project is performed to test the safety and efficacy of an highly innovative. Oh, I'm sorry. Non vedo qui. I'm sorry. Okay, possiamo togliere. Okay. To test the safety and efficacy of a highly innovative gene therapy approach with the dual AAV in the retina of Usher 1b patients. In dual AAV vectors, the 2 halves of a large transgene coding sequence are split into two EEV vectors. And Professor Alberto Ricchio's team demonstrated that dual EEV transduce myosin 7A gene in animal models, mice, pigs, and non-human primates. We began this project in 2018. The project is composed by two parts, a preclinical part and a clinical part. The preclinical part included production of dual EEV vectors, testing the safety and biodistribution of dual EEV vectors, production of clinical grade dual EEV vectors for a clinical trial, and at the same time we performed a natural history study of Usher patients. Both these parts of the project finished about 2 years ago, and then we designed the gene therapy clinical trial. So we started a phase 1 clinical trial last July, treating the first patient. So we performed a natural history study in the patients that was very important for the clinical trial design. This is a multi-center, prospective, longitudinal, observational natural history study to evaluate disease progression in subjects with Usher syndrome type 1B and to identify the most suitable patients for the clinical trial on the basis of ophthalmological aspects and disease progression over 2-year follow-up. As I told, 3 clinical centers participated to the study. Our University in Naples, the colleagues from Madrid, Professor Carmen Ayuso and the ophthalmological team, and Professor Ingeborg van der Born from Rotterdam. We enrolled 53 patients, 29 in Naples, 16 in Madrid, and 8 patients in Rotterdam. All patients showed mutations in both alleles of myosin 7A gene, as you can see in this table. This is the study schedule. We performed best-corrected visual acuity, visual field, microperimetry, fundus autofluorescence, OCT, full field ERG at baseline, 1 year and 2-year follow-up in all patients. We had 33 patients with cochlear implant and 9 patients with hearing aids, 12 patients in pediatric age, and 41 adults. These are the main clinical parameters at baseline in terms of best-corrected visual acuity, visual field, OCT, both central macular thickness and EZ band width, and fundus autofluorescence patterns. We found 3 different patterns of fundus autofluorescence: an hyper-autofluorescent ring in about 40% of patients, a patch pattern in about 30%, and severely decreased FAF in about 18% of our patients. And you can see In this slide, the most frequent fundus autofluorescence patterns are autofluorescence ring evidenced in 22 patients with a median age 22 years, patch pattern in 16 patients, median age 45 years, and severely decreased FAF in 9 patients, median age 40 years. So, we correlated the best corrected visual acuity with the age of patients. And as you can see in this slide, best corrected visual acuity at baseline was significantly age-related. Best corrected visual acuity was preserved in pediatric subjects, whereas from the second decade of life, some patients showed a significant reduced best corrected visual acuity, while a significant number of patients showed a good best corrected visual acuity. A second observation about the progression of the disease, we noted over the follow-up a statistically significant best corrected visual acuity loss about 2 and 4 letters at the first and second follow-up visit, respectively. We correlated best corrected visual acuity and fundus autofluorescence pattern. Best corrected visual acuity was significantly better in eyes with hyperautofluorescence ring, as you can see in green, compared to eyes with patch pattern in red and severely decreased FAF in blue. Visual field using 3-4E stimulus size was significantly age-related too, but no statistically significant differences were observed over the follow-up, probably because of enlargement of the first follow-up visit due to learning effects. We correlated the visual field with the FAF pattern, and visual field was significantly larger in eyes with hyperautofluorescence ring, as you can see in green, compared to eyes with patch pattern in red and severely decreased FAF in blue. Central macular thickness was not age-related. Central macular thickness was quite preserved in most patients, also in adult life. Moreover, no significant decrease in central macular thickness was observed over the follow-up. Central macular thickness was significantly more preserved in eyes with hyperautofluorescence ring compared to eyes with patch pattern and with severely decreased FAF, as you can see in the graph. We correlated EZ bandwidth with age of patients, and EZ bandwidth resulted age-related. A trend of EZ bandwidth reduction was observed over the follow-up, although it didn't reach a statistically significant level. We correlated EZ bandwidth with FAF pattern, and as you can see, EZ bandwidth was significantly greater in eyes with hyperautofluorescent ring in green compared to eyes with patch pattern and severely decreased FAF, as you can see in red and in blue. These are three examples about the correlation. And you can see in the first case, a 12-year-old patient, the presence of an hyperautofluorescence ring, large visual field, and quite preserved OCT. In the second patient, 36-year-old, we observe a patch pattern, a reduced visual field, and a reduced central macular thickness with disrupted EZ pen. In the third example, a 44-year-old patient, we have a severely decreased FAF, a visual field detectable only with the 5-4E stimulus sites, and a markedly reduced central macular thickness with no detectable EZ band. So, we confirm for the first time in a prospective setting the relatively slow natural course of the disease. We provide valuable information about fundus autofluorescence as an objective readout to accurately monitor and stage the progression of retinitis pigmentosa in patients with Usher 1B. So, at the end, I'm happy to show you the scheme of the Luigi phase 1-2 clinical trial. Design, as I told before, we started the clinical trial last July, treating the first patient. Then we treated the second patient in October, and we will treat 15 patients in the trial. These are the key inclusion criteria: male or female, adults between 18 to 50 years, obviously with biallelic mutations in myosin 7A gene. We divide the patients in two subgroups: patients with low visual ability and patients with moderate visual ability. And we will treat these patients of both the categories with 3 different doses of the drug: low, medium, and high. The primary endpoint is the safety, and then we will evaluate also, I hope, efficacy of the treatment, considering best corrected visual acuity, low luminance visual acuity, full field stimulus test, microperimetry, and mobility test. Currently, I can tell you that we didn't observe any adverse events in the 2 first treated patients, no inflammation on ophthalmic exams, no adverse event findings on OCT or FAF. Obviously, we have no results in terms of efficacy because it is too early, but I can tell you that till now there have been no safety concerns. These are our recent papers on the topic, and I would like to thank a lot my team for the great effort in conducting this study. Thank you very much for your attention.
So thank you very much, Professor Simonelli, for this great overview of Usher Syndrome 1B and the currently running trial. And now we would like to proceed to the third talk by Dominique Sturz about the patient-relevant aspects of the daily life. Thank you.
Yes, thank you, Katarina, for the nice introduction, and thank you to you both for your very interesting presentations. Well, so a warm welcome also from my side, and a very good afternoon or evening, depending on in which time zone you are based. So I'm giving you a very broad perspective of what is relevant for patients and their families. And but let me maybe first of all introduce myself. I'm the ePAG chair at ERN-EYE. And we all might know that ERNs have been established as a new institution by the European Commission with the overall mission to bring better diagnosis, treatment, and care to patients with rare diseases such as Usher syndrome. So at the end of the day, it is all about the patient. And ePAGs, the European Patient Advocacy Group members, are involved. So also myself in all activities at ERN, just to make sure that everything what is done at the level of ERN-EYE is done in the interest of patients. Me personally, I have a long history with Usher syndrome, dating back to when my younger daughter was diagnosed deaf in 1997, when she was 1 year old, without knowing anything about Usher syndrome at that time, of course. And this is also when I started as a patient advocate and patient representative at the Austrian Cochlear Implant Association and also at the European Cochlear Implant Users Association. And when we received an additional clinical diagnosis of RP, retinitis pigmentosa, when she was 9 in 2005, my focus of patient representation and advocacy activities became completely different and shifted to the wider Usher and the rare eyes, the retina, the rare eye, and later also to the rare disease space at large. So I'll be sharing my perspective as a parent with you, giving you a personal insight. I'll also be sharing a perspective as a first contact and family advisor, giving peer support to Usher families during especially their diagnostic journey, but their whole patient pathway, let's say it like this, and give you the insight of the wider patient, Usher patient community. I'll also give you a perspective, or I'll include the perspective of the wider rare eye disease space and the rare disease space, and that on a national and international level. So I have quite a complete picture of the heterogeneity of how diagnosis, treatment, and care is done in European countries for the whole rare disease space and especially for the Usher space, of course. So, and this is all included in the findings that I will present to you. So when we look into the question, what is relevant to patients, we have some key areas which we will see in the next 10-15 minutes. We'll look into diagnostic journey, what is relevant there. We will also look into the entire patient journey, not only the diagnostic, but also the care pathway during the whole life, if we can say so. We'll look into the, let's say, the environment, the clinical setting, and the communication, what is relevant for patients and their families there. And we will also look, we'll have a brief look into science and research, what is relevant from the patient perspective in this key area. So first of all, let's look into the diagnostic journey. The thing is that when it comes to diagnostic journey, we know that in Usher syndrome, a confirmed diagnosis can only be a genetic diagnosis because there are diseases that look similar to Usher syndrome, that are mimicking Usher syndrome. So to know if it is Usher syndrome, we absolutely need a genetic diagnosis, which is not only relevant from a personal point of view for the family, but beyond that, for the wider patient community, to other stakeholders, and also those benefits from having that accurate genetic diagnosis also available to the wider patient community and beyond to other stakeholders will have a positive effect, will kick back to the benefits of the patient and the families at the end of the day. And when it comes to diagnostic journey, in some cases, still today, although we have genetic testing available, much more available than just some years ago, although diagnostic journeys are linked to, I would say, a diagnostic odyssey. This kind of odysseys, unfortunately, are still out there in some places, very much depending on where patients live, in which country they live, or in which part of the country they live, if it's in the countryside or close to a big city, and also depending on how the healthcare system in their country is organized. So I'll give you just an example of an odyssey, quoting my family. My family went to all stages of the diagnosis, from no diagnosis at all in 1997, when my daughter was 1 year old, no diagnosis at all in 1996, when she was born, to the diagnosis of one symptom in 1997 when she was 1 and her deafness was diagnosed because she didn't start to speak. There was no standardized newborn hearing screening at that time available in the country, not in all places of the country. So she was implanted with cochlear implants bilaterally and early, very unusual for that time, and has been raised in an audio environment then. Then we had the third step of the diagnosis of a second symptom, which was RP. It was a clinical diagnosis of retinitis pigmentosa in 2005 when she was 1 year old, which was a kind of, I would say, presumed or suspected diagnosis of USH1 altogether with her deafness and her hearing rehabilitation with cochlear implants. But it was, of course, not a confirmed, not an accurate, not a secure diagnosis yet. And her diagnosis of Usher syndrome subtype 1B was genetically confirmed in 2012 only, when she was 16 years old. So why am I telling you this? One of the key elements that are relevant to patients and their family is certainty. So in our case, you might think that I'm kidding, but the genetic confirmation of the diagnosis was a relief, because there was certainty. We knew the cause, we had an explanation, and last but not least, there was no feeling of guilt anymore. A lot of parents feel guilty. So we knew at once that we didn't do anything wrong. It was just a mutation, just a joy of nature, so to say. And another aspect here in this context is that before we had that high level of uncertainty linked to the quite, let's say, to the symptoms raising concerns. There was the deafness diagnosed at 1 year. There were those delayed motor skills that we have also heard before in Katarina, in Professor Stingl's presentations, and the balance issues, which we didn't know why they were there. We just had to cope with them. There was the clinical diagnosis of RP later. And then there were some unclear seizures, vertigo seizures from age 11, and we still didn't know where this all came from. And so we were asking ourselves, well, what is out there? What else is out there for our daughter and for us to cope with in life? So certainty is a very, very relevant key element, and in terms of what is relevant to patients. Also, because when they know what it is, when families know what they have to deal with, they can go over to more targeted and to more effective actions. And let's look into those targeted actions and why this is so relevant and so important to families, especially. Parents are responsible for their children. Parents build and create an adequate environment for, let's say, school, hobbies, education, family, friends, etc. And affected children, when parents are able to do this because they have an accurate diagnosis and they know what to do in a targeted way, those affected children, they just grow up with it. They would just grow up with it, protected by their family. And the other side, and that still happens today a lot in some countries and in some places, is that especially teenagers or young adults who have been diagnosed late, that when they receive a devastating diagnosis in a stage of life where, imagine a teenager having their heads full of dreams and visions and plans for their lives, this is much more devastating than having the early diagnosis in the family and the parents preparing the environment for the children. So they also can, in a very targeted way, connect to the patient groups or build some, as I did, for example, or many other, there are many other examples out there. They can go for targeted coping strategies and reduce the individual burden for themselves and also for their family and also for their child. They can build, and this is all very relevant to the patients, they can build individual resilience to be able to support their children thriving. And another aspect that is relevant is to make plans. That what families want to do, they want to have a plan for their child, for themselves, children, or young teenagers or young adults. They want to have plans. They want to make plans. They also want, those families want to take informed decisions about treating the hearing disorder, for instance, very early by providing hearing aids or cochlear implants depending on the subtype of Usher syndrome. Hearing, good hearing, excellent hearing is very important because it is one way to compensate vision loss when it progresses later in life. Also to have a plan for how to handle the vestibular dysfunction in the form of kind of balance training, etc. Also a quite well trained balance can become very, very relevant later in life in young adults when vision loss progresses and when they have to reduce speed when they walk. Because for balance, you need speed. And if you have balance issues, you need more speed. And when you lose vision, you will have to reduce speed when walking. So these are both very relevant things to compensate vision loss, especially later in life. Also, in terms of family planning, I mean, you have heard all those questions. The first thing people ask is there a treatment out there and where can I get it? And the second one is, will my other family members also develop Usher syndrome? How likely is it that my cousins, my brothers, my children, my grandchildren, who else in the family will develop Usher syndrome? So also in terms of family planning, it's very relevant to have this accurate diagnosis and also to access the adequate experts, to find adequate support, be it medical, financial, social, be it the disability services, and also to find the related research and clinical trials, if any are out there, or upcoming clinical trials. So that are all key elements of relevance for patients. Another one, and that's one I like very much, is empowerment. Let us talk about the relevance of empowerment of patients. A confirmed diagnosis helps to build identity. Where do I belong to? Who can I reach out to? Can I find similar families? Can I find similar patients? Can I build a network, even a network of patient-clinician partnerships or a network of research partnerships? Or can I find any that are already existing? Can I create a powerful community altogether? Can I bring peer-to-peer support to other families? Can we exchange support each other? And can we all together create a powerful community of patients and families, of healthcare professionals, also of local healthcare professionals who are maybe not experts yet, but who we can link to international experts, like we find them at ERN-EYE level, for instance. Also a network of support services of, let's say clinicians, researchers, and scientists all together. And last but not least, also of health policymakers and stakeholders. If you need to advocate in your country or at European level, for instance, for some rare disease strategies. Another key element is having access or building experts in special knowledge. It's about creating knowledge. It's about education of future experts. It's also about patient It's about guidelines or patient care pathways or patient referral pathways. It's knowing who the national members of DRNs are, for instance, and to have access to that international pool of expertise. And all this, at the end of the day, to have or to deliver more informed and, let's say, more targeted treatment and disease management, also to reduce ineffective treatment and disease management, which might in some cases still be out there, with the ultimate goal and mission to reduce the burden, not only for the individual and their family, but also for the healthcare systems at large, and also the social systems, if we want to broaden the scope a little bit. Let us also look into data. Why are data relevant from the patient perspective? Well, we can build data when we have a confirmed genetic diagnosis. And usually a genetically confirmed diagnosis goes along with a coding. It could be an ORFA code or an ICD-10 or ICD-11 code, which can be applied during all stages of the diagnostic and the patient pathway, let's say. And these data can be used to track and to give visibility in systems in an anonymized way, of course. But this is of high relevance also for the patients, not only from the scientific perspective or from the perspective of healthcare systems, but it's also very relevant for the patient, that we can use those data to build registries as we have them at the moment as we are building them at the ERN-EYE level, the rare eye disease registry, and the retina registry. And these registries are supposed to be interoperable with what we call the European Health Data Space, so data at European level, at the level of the European Union. And these should be interconnected again back with the national health data hubs at the hospital level, of course. And why is this relevant also from the patient perspective? On one hand, we can identify patients, we can monitor results, we can quantify patients' needs, when we can track how many are there, when the whole community is visible in the systems. So we give them what I call visibility in healthcare and in social systems, so that information can be given to health planning and to social systems, to the planning of the healthcare altogether. Information can be given to research or to educate, which educational measures have to be taken. That visibility also can support to identify, no, that's not what I'm saying, can support to identify the burden of the disease on the individual and their families, and also the burden of the disease in the whole context of society. What are the implications for society at large? And it can also support to estimate costs and give by that access or allocate appropriate funding to patients or patient organizations, to hospitals, to research, and other stakeholders. And these are all benefits that at the end of the day, of course, will kick back to the patients and the families in one way or another. When we look into setting and communication, so we go beyond far beyond the diagnostic pathway now, the whole patient journey, we want to meet their patients' needs and expectations. And there have been some clear do's and don'ts identified. So during all medical appointments, we want to make those a better experience for patients and their families, from the very first contact with the healthcare system to a confirmed genetic diagnosis, during all eye, ear assessments, follow-ups, interventions, if any. So there are some reports from family stories, which we could identify and conclude to some very, very clear and simple do's and don'ts. And I have some of them summarized here in the next slide. I know but out there in the clinical setting, very often there is not much time and we're under pressure and have to think about many things at the same time. But there are some very tiny and small little key elements. If you manage to think of those, it will really help a lot, because it's all about trust at the end of the day. So the moment or the wording you use will be decisive for if a patient or a family will trust or distrust in you and in the healthcare system, and adhere to what is necessary later as a protocol. So when we talk about the diagnosis, a first announcement of a type diagnosis, or even just a suspected diagnosis at the very beginning of the journey, the wording is really, really key. So just talk about changes in vision. I know that in many cases, or in many places out there, that happens already, but we still see also other things happening. Avoid the word blindness, and please, in the first announcement, never ever use the word deafblindness. Just use the positive and the words. Be honest. We don't have to lie to patients because they want to know the truth, but with the right wording, that will help a lot, not to lose trust and not to unnecessarily devastate them completely. And when we talk about changes in vision happening later in life, that's the truth. And it doesn't sound so brutal to them. So, and what they want to know, what this means for their family or for their child or for themselves when they are affected themselves, for the dreams, we want to know what this means for our future. So, and the most positive and the best way to talk about the future and the perspective for the patients is just to focus on what they can do despite the diagnosis, also in just using a positive wording. We can talk about, let's say, that there might be some changes in the future, or there might be some adaptations necessary in the future, but that's enough. And if you don't know what to say, it's always good to say, we don't know yet, because it's a broad spectrum and there are so many developments out there. So let's look into what is possible now and what you can do right now. Also very helpful has always been to connect, especially after the announcements of the diagnosis, the patient and their families to positive role models, if you know of any, to a family that is further in their journey and who copes quite well and who can give motivation and give some exchange some information. Connect them to Usher groups or Usher family groups if there are any out there. I've been around one in Austria since 2014, the Usher Initiative Austria. So, and it's a very successful concept. If you have, in some countries, you have big organizations like Katarina, Professor Stingl has mentioned before. In some countries, you have just a small group. That's also okay. Connect patients to positive role models, to families, and to the wider Usher and retina space. Please, especially not in the first announcements of the diagnosis, please do not connect them to the deafblind community. That will not be a good idea. They will find them anyway later in life. That's early enough. Connect them to the positive role models and to the Usher and to the retina space out there. The deafblind community covers completely different scope, and it's a completely different focus from what people at the first moment of the diagnosis would need. Some practical ideas that we have collected: always talk to the patient directly, even if it is, for instance, an adolescent patient accompanied by the parents or an adult patient accompanied by a family member or an interpreter. Always have face contact and pronounce very clearly. This is very helpful. And also ensure that face contact, because you will see also their reactions and they will feel much safer if you have face contact with them. Switch on the light, that is often forgotten after the eye exams, and give them time to adapt to the changing light conditions. I know in many settings we don't have enough time, but this is really simple. It takes maybe 1 minute to wait, and the patient and the family, they will just feel much safer and will feel more comfortable, and the whole setting will be a better and a more comfortable experience for them, and then maybe also for you all together. If you can, when you have to deliver information, use electronic format, prefer it to paper. And if you hand out information in paper, please think of large print and high contrast. No light blue and dark blue or things like that. I've seen a lot of them. High contrast and large font, large print is essential to meet their needs. And another thing that is relevant is for patients is they want to have the feeling that they can do something, that they are not completely powerless or helpless. Maybe also you want to have that feeling when you have to submit a negative message or a devastating message. It's good to talk about the importance of a healthy lifestyle, because there is something one can do at least to slow down vision loss, the progression of vision loss. So talk about healthy lifestyle, talk about nutrients, also talk about medications or other things they should absolutely avoid, so that you and the patient have the feeling they can do something about their condition, although there is no dedicated treatment out there for the vision loss at the moment. And also give them a positive outlook and a positive perspective, talking about the availability of upcoming clinical trials and upcoming new treatment options, just as a positive perspective. That is very, very important. I've heard families reporting that they were told, well, there's nothing out there, so, and that's it. And that is simply not true. It is simply not true, because there is something out there, even if it is not ready yet. So let them know that there are herds of clinicians, scientists, and researchers trying to develop innovative treatments and to find cures. That's so important, and that is so encouraging for all of you and for all of us. Let's look into what else is needed and relevant to them. How much time do I have? Some minutes? Okay. It is integrated care and integrated disease management. So we should, if possible, it depends on which site at which site you are and how the setting at your site and in your country is. But what is really relevant is to cover all aspects of integrated care and disease management: the medical, the psychosocial, and the social. So for the medical aspects, it would be good to have, if you can, interdisciplinary panels for diagnostics if necessary, or also for other important decisions. It's good to have genetic counseling with all its implications, and it's good to have a plan for the regular follow-ups and assessments, and also a plan about treatment decisions, if any, for example, to treat the hearing loss. When it comes to psychosocial, it's a bit more complicated. In some sites, there is psychological support. If you can offer that, that is great, and you should integrate it into your care model. If not, it's just for the patient, it's just important to know where they can find support. Can be that you collaborate with some psychologists out there, or could also be that you can guide them and tell them where there are the relevant patient groups and patient organizations who can give them advice on, well, it's all about psychosocial, it's all about identity, it's about the social environment, it's about aspects of inclusion at school, education, work, family, friends, all together. We just need to find where, we just need to know where to find support if you cannot deliver it at your site. And similar, it goes for social services. In some cases, there is a social worker at the site, then it's good to connect the patient directly with them. And if not, just tell them where you can find the information. Again, it could be patient organizations or groups or other institutions where they can find information about disability service, assistive devices, O&M training, etc., etc. And sometimes it's enough just to have a family or a patient group on board that, let's say, once in a month can come into your clinic, to your site, and have, as a volunteer, that happens often, 1 hour to talk to patients that just have been diagnosed or have to take important decisions for the treatment plan or whatever. That is also a very good way to catch up with those patients and give them support in a more integrated way. And last but not least, what is relevant in science and research? Well, science and research as such is of course very relevant for patients to find treatments, especially to stop or reverse vision loss, which is the most unmet urgent need for patients with Usher syndrome. And there, I would say, it's all about patient, we call it patient centricity and patient partnership. So when we talk about unmet medical need, the question, who defines or co-defines unmet medical need? Who is this? Is it the scientists? Is it the healthcare? Is it the clinicians? Is it the researching industry? Is it the patients and the caregivers? Of course, when we can, we want to tick all those boxes and bring them together to define the unmet medical need and also the research priorities and the research questions. So when we ask for preferences, include the patient preferences, that is really, really relevant. And well, I'll give you an example. When we ask Usher patients, especially the younger ones, maybe teenagers, young adults, and their families, which of the senses should be prioritized in research? What would you think they say? Is it vision? Is it hearing? Is it balance? Well, it's clearly vision. So this is an important information because all our efforts should go there. And also other patient preference surveys could be very valuable to direct our efforts and also where the money should go at the end of the day. And also in clinical trial endpoints, at the end of the day, it's all about patient centricity and patient partnership. We are seeing a whole discussion around this subject at the moment. So, and we are seeing a shift, a paradigm shift to having endpoints co-defined. I don't say defined solely, but co-defined with patients, like the patient-focused and patient-reported outcomes, including the impact on their daily lives. So when we can, we should have patient involvement in all stages of the treatment development cycle, from the very first beginning when setting the research priorities to the very end, which is approval and also further on of innovative treatments. Well, as a conclusion, we can say that we have looked into the diagnostic journey, the entire patient journey and care pathway. We have looked into the clinical setting and communication and the environment that we can build there that is relevant for patients. And we have looked into science and research, what is relevant there. So altogether, I am calling on everybody here because you are the ones, otherwise you wouldn't be here, who are the dedicated ones, who are interested, you are our heroes out there. So I really encourage you to include your environment into what is relevant for patients and to disseminate the information and encourage other people in your environment to look into the recorded webinar, which will be made available afterwards. And yes, all this to give patients and their families certainty, to give them visibility, to inform healthcare systems, social systems, inform research and science, to build trust, to build adherence, to build comfortable settings, and to give access to the best interdisciplinary disease management and integrated care, and to innovative treatments one day, if any. So, and I'd also like to invite you to look into what ERN-EYE offers in terms of Usher resources. So there is the ERN-EYE Good Practices series leaflet for professionals. There is a #1, which is on how to welcome people with visual impairment in a clinical setting. And there is #2, dedicated more specifically to patients with Usher syndrome. And there is also a very nice video on that, an educational video, which is more or less a summary of the Good Practices series leaflet. It's a very short video, just look into this. There are e-learning programs under development, and certainly there will also be one for Usher syndrome one day. At the moment, there is one under development for pediatric ophthalmology, which is for all rare eye diseases, but which will also cover some aspects of what is relevant to patients and their families and what they expect from HCPs in the clinical setting, etc. And there are also clinical practice guidelines and consensus statements and care pathways under development. And certainly one for Usher syndrome is in the plan for the future. And last but not least, there is the clinical trial database by disease, where everybody can see what trials, also natural history studies or interventional trials, are being led at the level of ERN-EYE members. And last but not least, I'd like to inform you about a very important event next year, ASH 2025, which is the International Symposium of Usher Syndrome. It's 2 days scientific symposium and 1 day patient symposium called Congressival. And it's from 19th to 21st June 2025 in Nijmegen in the Netherlands. And it's led by or organized mainly by the Stichting Usher Syndrome and the Radboud Medical University Center with some scientific partners, and also with many patient partner organizations like the one I lead. So yes, thank you that you have stayed with me till the very end. It's a long afternoon for all of you. Thank you very much. I really appreciate that you have stayed till the end, and I'm happy to take your questions, and I hope to see you in Nijmegen next year.
So thank you, Dominique, for this very extensive and excellent overview of patient and family aspects of Usher syndrome. So by having said that, I thank you all for dialing in, for listening to our webinars, but even more, I would like to thank all the speakers, Dominique and Francesca. Thank you for your excellent presentations.
And thank you.
And hopefully see you at some other occasion online.